Whenever we think of doctors and hospitals and medical care, we're generally just thinking about someone has something wrong with them and it needs to be fixed.
We feel terribly demoralized. I'm not the person I used to be. This person that I am, this is not me. And a lot of it is because we place worth on our function, what we can do, how we can participate, rather than what we are, who we are.
And there's a beauty in being around that person and supporting them, and to be truly compassionate, to suffer with the person. That moment where I watched him take his last breath isn't as much of a sad memory as it was a beautiful memory. To know that there was a certainty in my heart the moment I saw him take his last breath, that there's something more than this life.
Hello everyone and welcome to the Against the Grain podcast, where father and son talk faith and footy. I'm your co-host, Father Ben, a Catholic priest for the Archdiocese of Sydney, joined today by the other co-host, my spiritual son, Anthony. Welcome.
Thank you. How are you?
I'm well, mate. I'm well. And today we have a very special guest, Dr. Charbel Bejjani, palliative care specialist working in Sydney. Charbel, you're very welcome to the show.
Thank you for having me. It's an absolute honor and pleasure.
And we're doing something a little bit different this week. I know we've had a lot of fun in this season. This is our 14th episode now. But only a couple of weeks ago in New South Wales, the euthanasia legislation went live or became enacted, so to speak. And so we're going to have a bit of a serious chat about that this episode, because there's a lot of misunderstandings, misconceptions about these laws. And so for that reason, at the beginning of this show, whilst we do encourage this show as a very family-friendly show, we are talking about some very deep topics. So I'll leave that to your discernment at home for those listening as to whether or not this is one appropriate for your really young kids. But it's definitely appropriate for our teenagers who have been flooded with this type of thing on their social media. And we're just going to have a really raw and honest and vulnerable conversation today about what has happened in our state, what's been happening around the world for decades now. And New South Wales, it passed in New South Wales a few weeks back, so we're going to get into that a little bit. So, Dr. Charbel, you are a palliative care specialist.
Mm-hmm.
So can you please explain to us what that is?
Right. So I am a specialised physician. So just to explain sort of medical training, you finish med school in New South Wales, you do usually 2 years of what we call pre-vocational training. So before you've chosen what your specialty or subspecialty is. And then you sort of then get to choose. You can prolong that. You can do 3 or 4 years without vocational training. But then at some point you might want to, usually most of us will choose a vocational path. And there are sort of certain big paths. The two sort of big ones that people sort of will talk about are surgical training and then physician training. And then there are various other training. There's general practice training. There's anesthetic or critical care training. There's things like ENT or ophthalmology. All the different things. I'm not going to bore you with it. So I chose physician's training. So it's actually quite general physician's training, and it's a physician is I guess the easiest way to explain it is any sort of non-surgical specialist. Okay, so your cardiologist, your kidney specialist, your lung specialist, your heart. Pick an organ, pick a system. Those who are non-surgical specialists would generally be physician trained.
Okay.
So that was my training pathway. So yes, part of my general training, I had to learn everything from top to bottom. So you do the general cardiology, neurology, respiratory medicine, etc. And then after those years of general training, you sit a few exams, you, by the grace of God, pass, and then you choose your subspecialty after that. And I chose palliative care. There was another 3 years of advanced training on top of that, with various things that you have to complete and do. And since 2019 I've been a palliative care specialist, and thanks be to God I was able to find a job readily, easily within the city, and that's great for my family. And it's been I'm generally I'm a public servant, so my substantive role is in public hospitals. And that's where palliative care a lot sits as well. So that's my sort of very abridged pathway. to where I got to in palliative medicine. So yes, I'm a fully fledged specialist doctor with many years of training under my belt.
Okay. So it's for that reason that we've asked you on, because you know what kind of effect these laws can have, especially in the area of in the area that you work in. But just briefly, what draws you to that particular specialty field?
Look, that's not an easy question to answer, because I think a lot of it was heart, and a lot of it was, where does my mission lie? That's a personal journey of mine, far from perfect, but generally throughout study and training, I got married throughout my after med school. So just right after med school, I got married and started my married life as a doctor. You just sort of, I guess, you're to me, it was a bit like soul search, a bit like, where do I belong? Where do I fit in? And I guess a part of me was always, where can I, I've had such a very privileged life as a young kid and growing up. Thanks be to God, I had a great family. Didn't really suffer much. It was quite a good life. And I just felt like I'd be given a lot of things, and I want to give back to the way that I can. And the way that I'm geared towards. And so there's a lot of sort of searching, what talent has God given me? Where do I belong? And look, I sort of had palliative care really in the back of my mind, and sort of early, even in my, even at school. I remember my high school teacher, who's now my neighbor, actually, he remembered in year 10 when I said that I wanted to do something in palliative care. Now, I don't remember saying that. He has that memory, and I'm like, wow, okay. These funny things that God puts in your heart and your soul. But specifically, my first year as a doctor, so you're an intern, and after doing med school and you're so into medicine, and yes, we're gonna change the world. That young feeling. You might be experiencing that as a young. You're gonna change the world, and then you sort of get jaded by the system, jaded by the world, and you get very disillusioned, and you kind of think, oh, is this what life as a doctor is going to be like in the first year, where you're learning the ropes, you're learning the system, and it's important and that's necessary. And then it was the beginning of my second year out, so my residency, my first term in that was, fortunately, and through no choosing, in fact, I swapped into it only to get out of something else. I wanted to get out of a surgical term, and this was the only term available. So I actually swapped into a palliative care term. It wasn't something that I was searching for. And it was that term that reignited my love of medicine. It reignited my passion to say, yeah, this is how I can help people. This is how I can help patients in the way that God perhaps is allowing me to, as a doctor, with my talents and with just who I am and my gifts, which have nothing to do with me. That's all sort of God-given. And even funny, even saying that, is when I spoke to my mentor about it at that time, he said, look, don't box yourself in. Look, it's kind of like discernment, don't box yourself in so early. Look into other things. You may even want to do a double specialty or a dual specialty. And so I looked into, and I was really gung-ho about gastroenterology. I really enjoyed the medicine of gastroenterology. And something towards the end of my basic training, the basic physician training, I sort of fell out of love of gastroenterology. And then I got another term in palliative care, and it reignited my love. And it was actually when I went home to my wife saying, I don't know, it's time now to choose. And I don't know which way to go, because I was offered this job, that job. And it was like, I really am, I need to decide. And have had a problem in my life, just, deciding is so hard. So I let my family decide for me, which I've done a lot of the way. Maybe it's a cop-out or maybe not, I don't know. But it's sort of like, my decisions are not for me, they're greater than me. And so I asked my wife, and at that time she said, you know what, I've never seen you happier than when you worked in palliative care, which people might think is a bit of a conundrum, or a bit of a
contradiction.
Yeah, a contradiction. How can you be happy in palliative care, working with death and dying and life-limiting illnesses? But it was true, and I've never looked back, and I was so happy. And in fact, one of the nurses that I work with earlier this year, we were talking about, the grass is always green on the other side. No, I wish I did this, I wish I worked here. And she was just saying, well, I can't see you as anything else. This is, I think, who you're meant to be. My wife sort of says the same thing. A lot of people around me say the same thing, so I'm going to say the same thing. I'm very happy where I am.
Isn't it amazing that there was peace in what you were doing in those two terms with palliative care?
True.
And it was a loved one, the woman that knows you most intimately, that realized that that's where you found your peace. So if you were discerning this decision on your own, please God, you would have made that decision yourself. But it was a loved one that saw it in you, and you haven't looked back since. That's beautiful.
Yeah.
That's a beautiful thing.
Look, I maybe this was not God's plan A for me. I don't know. I guess we'll only know in another lifetime. But whatever it is, I guess I have that quote from St. Augustine, which I've been quoting since high school, which is, whatever you do, do it well, and you would have pleased God. So I'm hoping. That's my hope. That's my hope.
Now, speaking of your wife, just very quickly, happy wedding anniversary today.
Thank you. Yeah, 12 years today. I'm still surviving, and more importantly, my wife is still surviving.
Happy anniversary,
we have to say it because she's been so kind on the day of an anniversary for you to come into our studio in the heat and talk to us about this very important thing. And I think that's just another example of her support and affirmation of what you do.
Thank you.
So it's a beautiful thing. We're praying for you both on this your wedding anniversary.
Thank you.
Thanks for being here.
Thanks be to God.
So give us a definition of what palliative care is.
Yeah. So I give lots of talks, sort of palliative care 101. So I'm just going to go really to the summary page of it all, because I've got a couple of sort of lines of it, or a couple of slides on it. But really, what palliative care in a nutshell is, who are my patients? So a cardiologist can very easily say, my patients have problems with the heart, non-surgical. And if there's a surgical problem, I send them to the cardiothoracic surgeon. Very simple, isn't it? Respiratory physician, the lungs; kidney physician, the kidney, etc. What's a palliative care physician? What do I look after? What is it that, is it a system? Is it a thing? Well, I look after patients who have a life-limiting illness. You can term that life-threatening illness. You can also term that as a terminal illness. So a progressive, advanced, life-limiting illness that naturally will shorten someone's life. So that's my demographic. I don't deal with an organ or a system. I deal with the person. And that's sort of why I fell in love with palliative medicine. But to continue, sort of, don't want to digress. So they're my patient load, is patients with a terminal illness or a life-limiting illness who have reduced quality of life for whatever reason. And I want to help them live well. So everyone thinks palliative care is about death and dying and the sadness around it. In actual fact, it's actually about living. And so what I want to do is help these patients who are we're all on a road to end of life, but obviously we're on a very clearer road, or closer path to end of life. And I want to help them live well, and improve their quality of life. Does that sort of help? Yeah. And so we see we shouldn't be just limited to patients at the end of life. When I say so, the normal understanding of that is at the last days, minutes, hours, maybe weeks. I'd love to know a patient in their last 12 months of life. And if you think about it, that means I have greater time to build rapport with them, to build trust with them, but also a greater capacity to actually improve life. Because if I meet them right on their deathbed, I'm improving their dying process, which is a part of life, but I just missed out on that opportunity to actually make a difference with them for a longer and a much more meaningful time. So the earlier I am able to know a patient who is on sort of this journey, the better it is for them and the better it is for me. And we definitely do deal with managed patients who are on treatment. So most people sort of equate palliative care with cancer, but we do lots of non-cancer. But we'll talk about cancer. The patients receiving chemotherapy, surgery, radiation, if they're not curative, even if they are curative, but it's a life-threatening illness, but let's keep it simple. Let's say it's a non-curative cancer sort of thing, and we want to do surgery or treat to try and reduce the burden or prolong life. I would like to be involved if there is a quality of life limiting issue there that I can help with. Now, certainly the medical oncologists, radiation oncologists, the surgeons, everyone involved, and all the nurses and allied health that are not palliative care are also wanting to improve quality of life too. So it's not something just completely limited to palliative care, but this is where our expertise this is where my specialty training is all about. So when things get a little bit hard for my colleagues, specialists in other areas, it's sort of like another layer of we need a little bit more help.
Okay.
So sort of the adage that sort of we use is that end of life care is everyone's business, and there is this sort of notion of what we call generalist palliative care, which all clinicians should, but not necessarily are, but should have some, I guess, competency with, quite standard, particularly in GPs in nursing homes or other specialists, medical and surgical specialists that deal with chronic illnesses that will eventually sort of things like chronic lung illness, chronic liver disease, chronic heart disease that eventually is terminal. That they should have some sort of, I guess, training and competency and comfort in dealing with the simple stuff, the simple symptoms. And when it gets a little bit more tough, hey, we need a little bit more help.
Okay.
Am I?
Yeah.
Does that sort of? Although a lot of words, I can be quite verbose sometimes, but I do want to.
It's important.
I do want to, I guess, qualify this that palliative care is a very nuanced, practical specialty. It's not something you can understand by reading a textbook or a textbook of the physiology of the heart. I'm picking on the cardiologist a lot today, aren't I? So reading. It's more. You have to experience it to understand it, and that was my journey. Is that I had to experience it. Go, oh, okay. That's what it's all about, and this is how I can affect change.
So to me, it sounds like it's a lot more of a holistic approach.
Without using that word, yes. Yeah, it is a holistic approach.
You're looking at everything. I'm sure you're probably dealing with family members.
Absolutely.
And I've had personal experiences in hospitals where families are, in a moment of crisis. They don't know what to do with their loved ones. The doctor is just the doctor treating a particular illness, whatever it might be, but you've got the whole gamut of a community almost, and you're having those conversations. So what does it actually do? If we're looking at a person, it doesn't have to be specifically it doesn't have to be a particular illness, but what do you do?
Okay. So first of all, you actually just you've done exactly how I present palliative care. What I've just said is what we are.
Yep.
And then my next slides are what we actually do.
Okay.
So thank you for doing that. And that was not scripted, I just want to say. But it's because it's quite it's quite a practical flow, isn't it? So first of all, I don't work as a lone wolf. I work in a team, and I work in a team of doctors, but more importantly possibly is I work in a team of nurses, allied health, volunteers, pastoral care workers as well. I'd like to have more and more of those, but funding limitations and service limitations are always sort of in the way. But it's not something that one can do on their own. It's certainly not something one can do on their own. So generally, it'll be sort of perhaps the specialist, the medical specialist could be if you want to call it the team leader or the person coordinating the care. But I'll certainly need my nurses to help out with symptoms. I'll certainly need my social worker to help out with the psychosocial element. I'll certainly need my pastoral care worker if the patient is so inclined to actually help with the spiritual element. And if they're particularly religious of any particular denomination, I would always ask to enlist help from their cleric, whoever. There could be a priest, could be an imam, could be a reverend, could be somebody from their community, could be an Aboriginal elder. So, that spiritual element. So just to summarize, we look after someone physically, but as you said, so we look after them psychologically, emotionally, socially, and spiritually, because that's what, in a broad sense, end of life care is all about. It's bringing that human person together, and a lot of the distress that we see is not particularly physical. There is a lot of physical distress. You dig under the surface. I call it when I train my juniors, I call it Charbel's iceberg. So the tip of the iceberg is what you see, is where they come to us into the hospital. I've got pain, I've got shortness of breath, I'm vomiting, I'm nauseous, etc. Okay, well, we can deal with that. Let's get some tests done. Let's, get some imaging. We'll manage that. We'll put some medications. We might need a surgeon involved. But hey, tell me about home. Tell me about who's your circle, who's important to you, what's your social construct like, what do you do for, what did you used to do, what makes you tick, what's important for you? Because we just harp on about pain and nausea, and the patient might get more and more distressed and just think, this guy's not getting me. I've got all this stuff, but I'm suffering a deeper pain. And that deeper pain can be, I'm young and I'm not going to see my family anymore. I'm elderly and I feel like a burden on my family. Or I'm lonely and I got nowhere to go and no one to speak to. It's these things that are I find the real suffering, I think, in the Western world, because I only work in the Western world, so I can speak to. But I think reading broadly, that's a problem. And in fact, Saint Teresa of Calcutta, again, I quote her at the end of all my presentations, says the real problem, particularly in the Western world, is loneliness, is not having God, but not having man as well. And that's where we can really make a difference.
Amazing.
Did I answer that question?
You did. You did.
Tend to go on a lot of
because look, this is very important for us, because whenever we think of doctors and hospitals and medical care, we're generally just thinking about someone has something wrong with them and it needs to be fixed. And what you're talking about are real existential questions, where we're talking about the meaning of life. We're talking about the purpose that someone might have in the world. And if they feel as though they lose that purpose, they can get really down in the dumps about things.
There's a word for that, and it's not depression, it's demoralization.
Demoralization.
So they get a lot of patients, it happens to us too, is that we feel terribly demoralized, terribly, we lose our self-worth. And that's not a clinical major depression, which is a more slow, pervasive problem where you're withdrawn and you might stop eating and drinking and you're hopeless and This is more of a, I'm not the person I used to be, and I don't see this person that I am. This is not me, and I'm distressed by that, because I'm not in my glory days anymore, as we were saying. I'm not who I am, and a lot of it is because we place worth, another word for that is dignity, on our function, what we can do, how we can participate, how we can contribute to the world or to our family, whatever, rather than what we are or who we are. Which we just need to read the first chapters in Genesis to say we're created in the image of likeness of God, and that's who we are, and that's where we, I guess, as Christians, and I'm stepping on your toes here, I think derive our dignity from. The challenges that I face are those who are not religious or spiritual, and those who don't have God or an understanding of any spiritual life, and they, how do they measure their worth? I find that really challenging. I find that really challenging. Yes. And if you don't have God, if you're agnostic or atheist or a practical atheist, you're worth something because of what you can do, what you can contribute. Because that's what the world tells us, right?
Yeah.
Rather than, you're elderly now, or I don't just deal with elderly, I deal with a lot with younger patients, but you're elderly now and you can't work, you can't pay your tax. I guess we're obliged to look after you. That's the feeling that people get. And now that you're sort of bedbound, now you need more care, more cost. Everyone talks about the inverted triangle, the aging population and the burden on the younger, and it's all quite negative, isn't it? I mean, it's real. But it's, rather than saying these guys contributed so much of their decades to their life, working, even if they couldn't work, they contributed by providing a family or providing a service, or just being around and enriching the value of life around us. And we should give back. I think that should be, I guess, the social part of care.
So I can't help but think that a question that would pop up in a lot of people's minds is, why is it so important to care for the social and the physical, not so much the physical, the social and the spiritual and the emotional aspects and things like that, if the patient's just going to die anyway? So why is that so important, and what kind of effect do you see on the person themselves towards the end of their life?
Oh, that's a really deep and, I guess, very important question, challenging question. Why is it important? Why do we care? Isn't it enough just to give meds to make the pain go away? And then it's like, look, I'm a trained doctor, get out, sort of thing. I've done my job, go sort your own life. Well, it's because it's not what we do. So just the definition of palliative care and how we've been brought up as a discipline is we are there to care for the entire person. And in fact, healthcare has grown in the Western world, despite what many people might think, to actually, at least we want to aspire to the holistic care of the person. All right, the core values that places like New South Wales Health would say is that we want to collaborate, we want to be open, we want to be respectful, we want to empower patients, we want to sort of have patient-centered care. It's really about that. So I think it's important because suffering, which is what we want to alleviate, is not just physical. And I think I've sort of made that clear, suffering is not just physical. I am a trained doctor though, so I'm not a trained psychologist, a trained social worker. I'm not a trained nurse either to give, physical cares. So I need a team around me. And I also not just need team on the floor, I need the management, I need executive, I need ministry, I need government sort of understanding that this is really important. So I think it's important because it's important to the person. That's where real suffering is. That's where there's a lot of real physical suffering, but that's where the deep suffering is. Because look, in my experience, I've seen patients with terrible physical suffering, but they're psychologically, spiritually, emotionally at peace. And it's beautiful to behold. In fact, it's inspiring. And I get inspired by a lot of my patients to say, wow, okay, if you can do that in the midst of your suffering, then that's how I want to be in my life and in my death. I think that's why it's important. It's important to the person. It's important to you. And that goes to the dignity of the person. I'm not just managing a physiological problem. I'm managing a person.
Can I interject here? The managing of a person, as you've said, is a team effort.
Yeah.
I'm assuming that's going to take a lot of time, manpower, and resources. So where does this money come from?
Yeah.
How is this funded?
Look, we'll talk about our situation here. So in Australia, in Sydney, New South Wales, so it's generally publicly funded. A lot of friends and family will ask me, can I go to a private palliative care? There really isn't one. So most palliative care units or hospitals, if not all, are publicly funded. And necessarily so because we are a resource, draining specialty because it's manpower heavy. We don't do these really big, expensive interventions and all that, but it's the manpower, it's the people that are involved. So that's where sort of your taxes are going, sort of federal tax for Medicare and state tax for hospitals. And that's where, if you remember Dominic Perrottet, when he was Premier, announced the $738 million. I might get those last two numbers wrong, injected into palliative care after voluntary assisted dying was passed, to say, well, okay, look, we want to make it clear that voluntary assisted dying is quite separate from palliative care, and part of the lobbying about sort of voluntary assisted dying was, okay, if you want to pass that, we need to then really, reinforce and make palliative care as robust as we can.
Because it seems to me, when we play the long game, when we're talking about a human life, we're talking about the whole of a person. That is exactly what is required from conception to natural death. We're people of community. We need people around us. And sometimes we need specialists around us, especially when managing life-threatening illnesses. And then just the counter to that would seem, well, the quick fix in all of this would be the passing of this voluntary assisted dying bill and the enactment of it a few weeks ago. Because that's not going to cost much, I don't think.
No.
But to look after a person in their last 1 to 2 years of life, that's a lot.
It does.
So what value are we putting on human life in this regard?
Yeah. Look, I think, and I guess we'll go into the nitty gritty of the voluntary assisted dying legislation, just so people understand the information. And I'm not defending anyone I'm going to call it VAD. Is that all right? It's just much easier to.
So
or
voluntary
euthanasia.
assisted dying is VAD or
VAD.
euthanasia.
Euthanasia, assisted suicide. Well, let's just call it one thing.
Yep.
It's easier just to say VAD because that's what it is in society. I think the proponents of it we just wanted choice. We want to be allowed to have a choice. Now, I don't defend that, but that's where they're coming from. It's not that we want to devalue human life. They will argue, no, we are valuing human life because someone's suffering intractably, and the most humane thing you can do is to stop it by stopping life. But we're not doing it. It's the person wanting it. So we're giving a choice. And that's part of the whole pro-choice mantra, I think, isn't it? We just want a choice. We just want a choice. We just want a choice. So I think that's where of course, there could be more evil things at play, and I think that's beyond this forum. But just when I've had a chat with advocates of euthanasia and voluntary assisted dying and all of that, I don't see them as evil people. I can see where they're coming from, and I can understand where they're coming from. And there've been people who have lost loved ones who are faithful and say, gee, I can understand where people are, how easy it is to think like that, because it can be extremely, extremely distressing and harrowing. So I just want to sort of add that to it. Can I ask about sort of the whole, it's a big team effort. There's one team player that I haven't mentioned who's I will say the most important team player in all of this, in terms of caring for somebody who's at end of life or quite unwell. Do you want to guess? Now I'm asking you the question. It's my show now.
Yeah, Blaze, you're the guest. Feel free to ask the questions. Look, everyone plays a part, I suppose. I mean, even to me as a priest,
yep,
I play a part in all of this too.
Yep. But that's not who I'm talking about.
No, and I wasn't giving you that as an answer. The person.
Close. Who would be closest to the person?
The family members.
The carers.
Yeah.
The carers. And so a big question that we get when we introduce palliative care, and let's say we're talking about end-of-life care. And one thing while I'm on there, I just want to say that palliative care is not end-of-life care. It's a part of what we do, but I don't just do end-of-life care. I just want to sort of make that quite clear. So part of it is the family members will come and say, well, what services can you give us for if we want to die at home? We want to spend our last days and weeks at home, which is a lovely thought. And if we can get that sort of done, we could. But we don't have anything extra or special beyond what is attainable within the public sphere. And people think of private. I've never seen anyone get private nurses because they're too expensive, hard to get, and you don't know what skill set you're going to get. I'm not sort of putting down anyone from a private agency, but palliative care and end-of-life care can be quite sort of difficult, and you need sort of good training. But it's the carers and those who don't have a robust social construct. And I don't want to say that it's their fault or anything. Some people could just have a small family or have a big family, but it's all dysfunctional. So if they don't have a robust social construct to look after this person at end of life, then it falls on public healthcare. That's just the long short of it. Those who are homeless, those who again have carers who are either elderly or physically unable, or have carers who are physically able but are not willing because they're too remote from the person. They're not. Look, I love this guy, but I don't want to look after him at home. There's a bit of love lost there, so to speak. Or there's no love lost there. Or it's just if you don't have that circle around you, and this you were talking to me about, so it's not just the patient, it's that. And I often will talk to patients about who's your inner circle, because we need them as part of decision making as well, because your well-being is now linked to their well-being. And if they're unwell, you're going to be unwell. And just in our recent the Oceanic Palliative Care Conference that happened in Sydney at the ICC this year in September, there was a real focus on caring for the carers. And one of the keynote speakers just said, if there's one thing, one favor you can do for yourselves while you're young is make lots of friends. For us, I guess it's make lots of family too. And family being your friends is because they're the ones who are going to care for you when you're elderly or when you're unwell. The fallback is, I guess, the health system, which is not always perfect. And sometimes that could be a barrier to being home. Or we might have to talk about nursing home, which isn't the end of the world. But we might have to talk about, you need to be in a 24-hour care environment. You can't do that at home. We can't provide that in a hospital because that's what we're geared for. So we might need to talk about another place.
One of the so we've spoken about a few places. So obviously, it can happen in the hospital.
Yeah.
There are palliative care wards. Where can palliative care be practiced?
Anywhere. Okay, anywhere. And the way that I describe it to families, not, you have a criteria and you tick these boxes and, okay, you belong there, you belong. It's more, what are your care needs? What do you need to be cared for? Sometimes patients are not medically complex. Their symptoms are quite well controlled. What they need is very good nursing care, because they could be bedbound. They need pressure area care. They need personal care. Or they're quite agitated or delirious or have dementia, and they need 24-hour supervision care. Now, can you imagine one person, a spouse, providing that 24 hours a day for 7? Nurses, paid nurses don't do that. That's why they have shifts. 8 hours, go home, recharge, come back for the next thing. Same thing with me. Whereas a carer, if there's no way to recharge, if there's no roster, if there's no rotation with other carers, family members, friends, or paid carers, can be very hard. So it can happen in hospitals, acute hospitals, what we call subacute hospitals. There's a few of them still hanging around, and a lot of them is where palliative care units are. And palliative care units are geared towards patients with complex symptoms or with very short prognosis to have end-of-life care there if they're quite complex. It can happen at home or nursing homes, really anywhere. Anywhere where it's appropriate for the needs of that person.
Okay.
And where we can provide, sometimes it's an environment thing, where we know you don't suit this environment, it's better for you to be in this environment. Let's say someone is very distressed, they want outdoors environment. Well, a subacute hospital could provide that. A couple of the units I've worked in have an outdoor courtyard for that social care, that social aspect of, and the psychological aspect of care. It's not all about drugs and whatnot.
Yeah.
It's about the whole person. Just some fresh air is amazing. Or just sunlight, or it just rather than being cooped up in a hospital. It all depends on the needs of the person in front of me.
So you have a very unique role in the health system. And the reality is that not a lot of people have experienced death or a loved one, maybe one or two in their life. They haven't experienced a lot of this. So sometimes experiences or observation of death can be very, very specific. So one instance can throw a person off. Yeah, and absolutely. That could have swayed them in the whole, well, I completely support VAD.
Yep.
But you, on the other hand, have had the experiences of looking after dozens, if not hundreds of patients. And you've been with them in those moments, in those last, whether it be years, months, weeks, days. So with that as a bit of a disclaimer, when we talk about one of the catchphrases, death with dignity, or so-called dignity, when we talk about that, what does a dignified death look like?
Yeah. I think that's subjective, isn't it? I have, first let me so I've prefaced by saying it is subjective. So it's in the eye of the dying, and it's in the eye of the dying's circle, family and friends. I think what's important to also note is, and I'm going to be very direct about this, is that death and dying is ugly. It is. And if you don't believe me, he did it. Yeah. He did it in the most ugly way, but it is ugly. It's not what you see in literature, movies, shows, Gone with the Wind, I love you. It's not Romeo and Juliet. We just, or The Notebook. My wife forced me to watch that. Part of the penance of marriage. 12 years of it. And love you. You don't just lie down next to someone and die. Like that doesn't happen. And for some people, they might die quietly in their sleep, slowly. Like my grandmother had dementia, and she just died a dementia death. She was, as my father described her, not me, she was a lantern with the oil running out. And so the flame just diminishes, and one day, some people die horrible death, sudden death, violent. Could be a motor vehicle accident, a heart attack, massive stroke, bleeding, who knows, So it's very variable, but generally death and dying is just an ugly business. And I think putting a theological spin to this, because it was never God's intention for us, was it? Came in with sin. It's a consequence of sin. And so it's I guess, a punishment, so to speak. So what's a consequence? as I teach my son, negative actions equals negative consequences. So we're stuck with it. But I've seen lots of, I guess, deaths, and dignity, I guess, what's dignified for one person is dignified for another. It really is a subjective concept, I think. From a theological and a Catholic perspective, I guess we talk about, are we treating this person as if they are a temple of the Holy Spirit and as if they are made in the image and likeness of God? Is this how we would have treated Christ if this was him, or his mother? Or, is this how we would have upheld respected their worth? Some people think, being incontinent in bed is undignified, whether you're dying or not. And I have a family member I was saying I was going to do this podcast. We're talking about dignity. And he said, well, I was very sick in hospital, very, very sick in hospital, with a very bad case of gastroenteritis, so diarrhea, sepsis in ICU. And this guy's a very robust middle-aged man, and he was being nursed in bed. And he's like, I understand what it means to be undignified in, I guess, a little you. Undignified in that is like, I'm a grown man, and I've got this young person or elderly person or some other person, a total stranger, cleaning me and wiping my bottom and doing all these sorts of things. That can be undignified. And we can understand that, can't we? It's kind of like, that's personal. But part of our role as healthcare, particularly healthcare professionals, is I go in there and just say, I chose this job. This is my job. And I do it with happiness. And I'm very happy to look after you. Very happy. Now, I say it as on behalf of the medical, but I also say on behalf of my nursing and allied health colleagues and the public health, we're very happy to look after you. We would prefer you to be clean and look well and presentable and comfortable. And what are you going to do? You're going to sit in your business, and that's undignified to me. But when you do it, let's go in there, let's clean you. Let's get you looking good. And nurses play such a pivotal role in this. Honestly, I work with such a great, I look up to them, really. They're just quite heroic, a lot of them, in terms of how they make a patient feel so dignified in the most undignified circumstances. As you can see, I'm not talking about physical symptoms here at all, because physical symptoms to me is something generally quite controllable. I have been through cases where are very intractable, like very, very severe. But the patients in those cases have never said, this is undignified, I'm in pain. They just say, this is excruciating, unbearable, I'm in pain, or I'm in distress, or I'm suffering, and physical stuff. But where the undignified comes in is like, this is not me. I can't look after myself. I'm not autonomous. I can't even just go to the bathroom. I can't walk outside. I can't get out of bed. This is not being human. Because we've got this picture of being human is an adult human who can walk and talk and do stuff on your own. Because that's what we're geared for in life, aren't we? We're brought up as kids and then adolescents to be able to be self-sufficient and look after ourselves. That's the human role, isn't it? But the bell curve quickly catches up with us, doesn't it? As we're born, we die. So as we develop, we sort of, generally speaking, unless you die a sudden death, we sort of undeveloped, or that thing sort of just starts to unwind. Yeah. So death and dying is not just, for some people, it's a sudden thing. For most people, for a lot of people, it is an unwinding of life, and we're not used to that. We don't like it.
You mentioned that it's subjective, okay? And I get that, because everyone has their own experience, and some families are so connected to their loved ones, other ones aren't. People have different pain tolerances and all sorts of things. And I get that it is subjective, but the reason that it's beautiful that you're on a show like this is to spread this message, to let people know that, yes, whilst you have your experience, we as a medical community can offer you so much more than the option that the government have passed into law. And that, to me, is why we've done this episode. We are, as I said at the beginning of it, we are going against the grain here. We really are, because, it's almost like a utilitarian society. The greatest happiness principle, pleasure, good, pain, bad.
Yep.
So I want anything to alleviate pain.
Yep.
And so, look, I can, like you've said, understand how some people would be in support of a law like this. But ultimately what I think it comes down to is when we as a society forget God or the existence of God, then nearly anything goes. And this is going to sound rather blunt, but it has to be said. When we as a society forget God and anything goes, this really speaks to the best we can do as human beings. All we can do is say, okay, the answer is let's kill each other.
Yeah, I mean, well, I think what's our ideal? What are we aiming for? What are we comparing ourselves to? And it just reminds me of St. Dominic's sort of 5 ways of proving God's, and one of them is sort of, well, you can't have better if there's no best. So you can't. That's the sort of the degrees. I'm doing a terrible job of theology, by the way, but it's if we don't have something, and honestly, I've come across all walks of life. It doesn't have to be Christian or Catholic, but if you have some sort of spiritual ideal outside of you, and you say that is dignity, and that's why I'm loved, because I am this, not because I can do this. I think that's where true happiness really comes from, no matter what you're suffering. And that sort of internal peace. I think that's really, really important, that inner peace that we're all striving for. For me, it's, well, if you don't have, let's say God, so let's say for us, if you don't have God or Jesus to look up to and to say, he's the reason to be happy, he's the reason to live, he's the reason to just go through what he's sending me, or to, here's the reason I have dignity, full stop. Then no matter what happens to me, no matter what anyone says, death, dying or not, if you're being bullied at school, if you're having life experiences, if you're being told off for this, that, the other, if you just say, no, my dignity is not tied to that experience, but tied to him, then how can you be ever shaken inside?
Yeah.
We're all striving for that, I think. Yeah. And that, I think it really comes to the fore, like when you boil broth and all that stuff comes to the top, because all that is actually coming to a culmination in death and dying. And your last with, this is real.
Yeah.
This is fine. It's not a business deal. It's not something you can, get yourself out of. Marriage is meant to be forever, but as in until death. But these days, you have that back door, not saying it's, but, in society you have, but death and dying, there is no back door.
Yep.
Well,
yep.
Until now.
Yeah. The remarkable thing about that is this: we need to be prepared and okay with speaking about things like this. We think about, in our context as well, in our Christian tradition, we have the martyrs. These were people that lived a life of virtue, that grew in virtue each and every day, so that the moment their martyrdom came, they were ready to accept it.
Yeah.
So for us as a society, if we become more and more godless, and we don't want to, and it's very, very simple. I mean, everyone's living their best lives on these things, and no one wants to think about suffering. No one wants to endure pain or the cross or do what it takes to get to that next level in life. No one wants to talk or prepare for that kind of thing, so that when they're faced with it for the first time, more often than not, in my experience as a priest, when I'm at the bed of a dying person and family members haven't even thought about this before, they are in, they're in all sorts. They're in hysterics.
It's existential distress.
Yes, it's a distress that they're in. Whereas I've walked into a room where I've got a family that believe in something more, that believe in the existence of an afterlife, and they're there silently and quietly praying at the bedside of their loved one.
It's still sad.
It's
and
sad.
And you should grieve.
It
and you should be upset.
Correct. But my point is that we need to be prepared, and we need to start those conversations now. The reason we're having this, which goes a little bit, left field of what we're doing on the podcast, is because this is new legislation. And if we just allow it to be one headline in the newspaper 2 weeks ago, everyone's going to get on with life. This is going to become the norm in society now. And if we don't start talking about there is more than just this, then people are going to continue those struggles in a deeper way. Because if we have a look at some of these Scandinavian countries that have had euthanasia for decades now, it isn't just the terminally ill anymore. With people talk about the slippery slope. People now with mental illnesses, people that feel lonely. So my point in this, and I'll let you take the last word on this particular point, but my point here is we need to be better prepared. And so that's why for us as Christians, we have failed. Some of our leaders have failed. Some priests have failed. Parents have failed. If we're not looking to the bigger picture, which are ultimately those 4 last things, death, judgment, heaven, hell. It's like we need to be talking about these things, not to scare people, but we need to remind people that there is so much more than just this. And if we can get our culture into a better rhythm of talking about this, then maybe when we get to these points in life, where we're in a hospital with a loved one that's on their last legs, maybe these conversations take a completely different turn.
You have a sense of peace. And I have another mantra. I have lots of mantras, sorry. I'm like an old man. And sometimes I feel like one.
Speak to us, wise man.
It's you die how you live. So if you've lived an angry life, if you've lived an unspiritual life, or you lived a very distressed life, you're just one of these people that just, you're just hard to get along with, and you're just not happy, and then you're gonna likely have a very distressing end of life journey. If you're one of those people who have attained internal peace, inner peace, whichever way, you're content, you're spiritual, and you help people, and you have a life outside yourself, you have a meaning outside yourself, you generally, there's sadness, definitely, but you generally really feel that peace in the person and within the family as well. But it's a lifetime of preparation. It makes me sort of think about, when you contemplate King David, he became king because he had a lifetime of preparation. He fought those lions and everyone sort of when he was young, not knowing he was ever going to be, but he did it. It was preparation. And we know where we're going to head, and we need to prepare now, all of us. Like we need to, I sort of look at patients and I go, golly, if this was me and I've lost this, that, and the other, and I'm their age and I have these kids, I think I'd be a mess. Maybe not. Or maybe I should work on myself now so that I'm not a mess, and that I can truly have that childlike trust in God that we all talk about in divine mercy. And, that just the acceptance. And there's that word, which is escaping me now, when you
surrender.
Thank you very much. That word is pivotal to me. So when you surrender, because our world is obsessed with control. We are obsessed with control, and we think we can control our lives. We can control little facets. I can buy this. I can wear this today, but I don't know what's going to happen tonight. I don't know what's going to happen tomorrow morning. I don't know what's going to happen next week. You make plans, and you should, but you should also understand that these plans can just fail at the flick of a finger, and then you realize I was never in control. But what you are in control of is when adversity hits you, what do I do in this situation now? That's the control that we have. What can I do now in this present moment? That's what I have control over. Me in this present moment. And hopefully you're with God to help guide you. But these external things that happen, or even internal things, health things, or people's deaths, or a car accident, or whatever, they're not in. No one can predict those things. You're not in control. And I think this happens to remind us, you're not in control, bud. You're not in control. And these are things that have happened in my life, not so much death and dying, and that's happened too, but other things where you're pulling this way and God's pulling you that way. And the more you pull this way, the more angry and upset and distressed. And the second you surrender and just go, it's like surrendering to the current in a river. You just fight less and you just end up in a nice lagoon. You're like, oh, all I had to do was just stop fighting. But I had to go through that. I had to go somewhere where I didn't want to go.
I just want to add to that in saying that some of the greatest saints live their life knowing that everything they do is in light of eternity, is in light of life after death. And so
As in every moment will be accounted for, every minute.
Yeah, yeah.
Scary, isn't it?
And even and when they get to this level where they're able to see everything in light of eternity, then things like suffering become so much more not just bearable but meaningful. And so they're not just there complaining about the suffering they go through. And obviously, when we don't go looking for suffering either. I mean, it like I've said before, it finds us pretty easily.
Life is full of suffering.
It is.
It's full.
It is. But they're able to find that meaning, to offer it up for their own intentions and things. And like you said, Father, as well, like we do need to be speaking about this a lot more. Like it's almost like criminal to speak about death now, because people don't want to think about it. They're like, no, like, please don't talk to me about that.
Yeah,
like,
we want to
so
stay
far
positive. We want to, and we
Yeah.
should be talking about life. We should be talking about
Yes.
life.
Yeah.
But life will end one day.
Yes, the reality of life.
It's the reality of us
Yes.
all, and we need to be talking about what's my journey going to be to that. We
Yeah.
call that death and dying. You can call it whatever you like, but death and dying, I just think, is just a chapter of life. It's the epilogue. Is that right? Yeah, that's the last part. It's what comes after. So yeah, no, totally agree. It is taboo in a lot of cultures.
That's
It is quite
Yeah.
taboo, and I struggle with that with a lot of my patients and their families. But I'm respectful as well, because I don't want to be the negative Nelly. I don't want to be there going in and causing more distress.
Yeah.
However, if something needs to be discussed, we discuss, and I very clear with my patients and their families. I say, look, if so-and-so asks me something, my role is to be honest and direct, but I'll do it very gently. Okay. So I teach my juniors, there's honesty, but honesty does not mean brutality. So there's honesty, but we can be charitable and be honest and speak about the obvious, what's going to happen or what is happening and where we're heading. But talk about it in a positive light. Talk about it in okay, well, if we can't do this, what else can we do? And I don't prescribe to the notion of there's nothing we can do anymore. That's said a lot, but what's meant is I cannot treat or cure this problem anymore. They don't mean there's nothing we can do and go home and sit in a corner and waste away. Maybe some mean that, I don't know, but I truly believe no one really means that. What they mean is there's nothing we can do for you anymore. In other words, there's nothing we can do to cure you or fix this problem that may end your life or may shorten your life, but there is so much more that we can do. And when they come to palliative care, I don't know when they come to us or whatever, or when we're introduced, that's half of my time is actually talking this stuff about what we do, what we're all about, what we're not about, the myths, and getting rid of those things, and just saying, and they're like, oh, it's not that bad or scary. I'm like, no, like I look scary, but we're here to try and make your life better.
Yeah.
Simple as that.
Do you find that there are a lot of misconceptions about palliative care out there?
Hugely, and amongst the lay and amongst the clinical and medical worlds, absolutely. There's a lot of misconception. Would you like me to go through a few of those?
Yeah, pick your top three.
Let me get to my Mythbusters page here because I don't want to miss anything. This is a carefully thought Mythbusters page. All right. So, first of all, palliative care does not equal do nothing. All right. People think, it's going to palliative care. You're just in a bed and, cleaned and you do nothing. And no, in fact, I'm not treating you as a part of a cascading slide of decision-making algorithm now. I'll chuck that. This is why I love doing what I'm doing, because every patient is very unique in their problems, and I just scratch my head going, okay, I like a challenge. I just say, how can I help you? Okay, I've got my training, I've got my evidence base, I've got this, how can I mix and match that to help you today?
That is so
today,
inspiring.
how can I? So it doesn't mean do nothing. It means it really, the way I like to practice it anyway is it's really patient-centered care. It's what are your needs, and let's come up with a shared decision together. I'll come up with a few ideas. You tell me if they sit well with you or not, and I'll try and push these things that I really think are going to be. But if you don't want them, fine. But let's go to plan B, C, D, E, which might not be the best thing, but for you, as in general, but for you, in your case, okay, I can see how that can be the best thing for you. I'm being very general because
Yeah.
I can't be specific because there's there's a million, billions of permutations of things that can happen.
Sorry, can I just quickly jump in? Part of my ignorance, but and this will show how very little I know, but how much I'm learning already, is patients only treated? No. Do they only get palliative care treatment when they're in the palliative care ward, or if they're called to a home?
Very good question. Very, very, very good question.
Yeah. Like say someone's in ICU, for example.
Yes.
And then they're on their deathbed then.
Yes.
Is there a palliative care doctor there?
So, very, very good question. So, in the public system in Australia, and I'll talk about New South Wales health as well, but generally mirrored everywhere, we have our inpatient beds that we look. So, if they're in my unit, I'm the admitting officer. I'm the person I'm the senior doctor who's in charge of this person. Yep. The decisions are not always made through me, but are made on my behalf, or I'm involved in all those decisions. The other thing is we have a consult service, and generally that can be a lot bigger than our inpatient beds. So they can be under the care of intensive care, under the care of respiratory medicine, under the care of oncology or geriatricians or whichever. But we come in and we provide that extra layer of specialist care. Sometimes we say, look, we're providing this extra layer of care, and the patient's needs are spilling over to we're happy to take over care. If that model is there in the hospital. So not all hospitals have that model. Some hospitals just have a consulting model. So we go there, you look after the patient, but we'll help you look after the patient. We have community services as well, which are, again, doctors and nurses, which are terribly, terribly under-resourced and funded, which I've done a lot of training, and sometimes I have gone out to patients' homes and done home visits and managed them in the home. But generally they're under the care of the GP, because GPs own patients, this way sort of I constructed in my mind. GPs own patients in the community, that's their governance. With the GP will say, oh, you got a problem with your heart, I'll send you to a specialist. But the specialist writes a letter back to the GP saying, thank you for referring your patient. I recommend X, Y, Z. Follow up with me when necessary. But the GP owns the patient. So we as palliative care will own, so to speak, the patient when they're in our palliative care units. There aren't many of them around, and generally the bed numbers are not huge. So that's sort of the model of care that we work in.
Okay.
Does that make sense?
Yeah. And sorry.
So I've palliated many patients in ICU, in coronary care unit, in general wards, in subacute wards, home, nursing homes.
Okay. And sorry, follow up before we
No.
continue with the misconceptions. Right. Is this for every, progressively dying patient, or
we have to be referred these patients, so they have to be identified by their medical governing person. It could be a general practitioner, could be another specialist.
Yeah.
They will have to recognize, okay, this person's got quite specialist end of life care needs, or has got nursing end of life care needs, and we need to sort of start to do a bit of advanced care planning. Okay. They might then refer. So I have no idea who's unwell to that degree in hospital. They have to be referred to me.
Yes. Yeah.
So I'm that sort of that extra layer on top of what's going on already.
Okay. Thank you for that. Yeah. It's perfect.
Palliative care, I've already said this, does not equal end of life care. So it's not synonymous, but we do end of life care. But then define end of life care. There are some people that will say end of life care is your last days, last minutes. There's a notion going out there that end of life care is your last, 1,000 days, which is like 3 years, which I think is a little bit long. But I think the tenet there is when things are slowing down, you might need to start thinking about your end of life care management and everything. But it could be the last 6 months, 12 months. It's arbitrary. It's not a number. Palliative care doesn't equal cranking up morphine and other drugs. But we do it to appropriate it to a symptom. If there is a symptom need, if there is a problem, the next thing to do therapeutically would be possibly to increase this or increase that or add this on. That's just therapeutics. So, but a lot of people will see this person's dying, morphine goes up, person died. So therefore palliative care equals increasing morphine till the person dies. That's what it looks like, but that's not what's happening. What's happening is should be happening is proper assessment of the patient and addressing their needs, medical, nursing and otherwise. That makes sense? Yeah. palliative care is not synonymous with, well, let's just sedate them until they die. Sometimes I do actually put in medications there to reduce someone's consciousness or level of awareness if that's their distressing feature, or if they have what's called a terminal delirium or agitation or brain failure, which is really agitating them, and we need to calm that agitation down. So give some calming medications, and often what you see is you get rid of that agitation, and what you see is the natural history of what's going on, which is the progressive sort of deterioration of the patient towards death. Very importantly, palliative care doesn't mean stopping all medications, stopping all interventions, stopping all investigations. It doesn't mean we don't do CAT scans or X-rays or we do what's appropriate. We do what's sensible if the goal of care is sensible. So I think that's sort of, I guess, in a nutshell, what palliative care is. And my last thing here is palliative care does not equal voluntary assisted dying. That's in the legislation as well. It's quite sort of clear that palliative care should be offered as part of a suite of options along with voluntary assisted dying. So it's not part of it. And certainly voluntary assisted dying in this state and other states is not part of the palliative care discipline or service as well in terms of public money and public service. Yeah. Okay. There might be individual clinicians that will say, even if they're palliative care physicians, they might prescribe to this and say, well, no, I do agree this for individual, but they might be, I guess, acting in the case of, representing themselves rather than the whole discipline.
Okay. Can we shift gears here now?
Let's do it.
And let's talk about this euthanasia legislation that's been enacted. But before we do, I've got the Catechism of the Catholic Church here, and I'd just like to speak to a couple of paragraphs which might help us understand why the church teaches what it does, and then maybe we can extrapolate a little bit on those things. So paragraph 2276 says, those whose lives are diminished or weakened deserve special respect. Sick or handicapped persons should be helped to lead lives as normal as possible. The following paragraph says, whatever its motives and means, direct euthanasia consists in putting an end to the lives of handicapped, sick, or dying persons. It is morally unacceptable. So just as a Catholic priest, I'm doing anointings all the time. I'm with people from beginning of life to end. And I just need to reaffirm exactly what the church teaches in this situation, not to be in any way, mean, or to be a person that's showing no empathy for what's going on in the world, because people suffer, they do. But it is a very clear teaching in our church that euthanasia is morally unacceptable. So whilst it might be a law in New South Wales, for us as Catholics, there can be no consideration for this. We cannot encourage our loved ones to participate in it. We can't write it into wills. We can't do anything along those lines, because what we're about to start to investigate here is that ultimately, whilst the government might say, yes, it's okay, for us, God is the author of life. Okay? So, voluntary assisted dying passed earlier in the year or last year? Last year. Enacted on the 28th of November
in
this year.
2023, yes.
Okay? So, let's talk a little bit about this now. But what I'd like our viewers and our listeners to do as we're talking about this is really have a think about everything Dr. Charbel Bejjani has just said in his area of specialty in palliative care. And I want us, this is a critical exercise now, I want us to really evaluate the differences in what's being said here. Because I think there is a true dignity to what palliative care specialists offer. And if it sounds as though I'm being biased, yes, I am. But the reality is that there is beauty in what we've been discussing. There is dignity in what we've been discussing. And in allowing someone an option to just say, I don't want it anymore, for us as human beings, for us as carers, for us as doctors, for us as priests, as family members, we need to want better for the person in distress. We need to want better for them. So can you talk to us a little bit about this legislation?
Will do. I'm going to be a little bit, legislative and just actually talk about the facts and the information. So I think it's really important to always, what's the word? Where you empower yourself with knowledge. You need to know what we're talking about.
You need to be informed.
What is euthanasia? Does that mean, I'm giving you a noose and you're going to, no. So who can access voluntary assisted dying in New South Wales? You've got to be 18 or above. So you've got to be an adult. You've got to be an Australian citizen or a permanent resident for 3 continuous years. Okay, so we're limiting who, you've got to be a New South Wales resident for 12 months. There are some caveats there, and they'll accept exemptions if you work there and live there and all that. Now, they're the sort of demographic tick boxes. So the other criteria now is about the disease itself. So you have to have at least one disease or illness that is advanced and progressive. Okay, so it's got to be quite advanced and progressive, not static. So static means you've had a problem with health, and then it's sort of hasn't deteriorated any further, like an amputation or a stroke. Sometimes, with most strokes, you'll have this deficit, and then you might get actually a little bit better, and then you'll sort of be like this until something else happens in the future. So advanced and progressive. You've got to have a prognosis, an estimated prognosis of less than 6 months. It's for neurodegenerative conditions, it's less than 12 months. Because there is a knowledge that neurodegenerative conditions can be quite ailing for a longer time and are slower to progress. So neurodegenerative conditions, the hallmark one is motor neurone disease, but there are things like Parkinson's disease, anything that causes a degeneration of the neurological system, and it's got to be progressive. Now, this is the clincher, the third disease criteria. So we said a disease that's advanced and progressive, a prognosis of less than 6 months or less than 12 months if you have a neurodegenerative condition. And it has to be causing suffering that cannot be relieved in a way the person considers tolerable. I'm going to repeat that.
Please.
Because there's an immense amount of subjectivity there to empower the person. Okay, it's not, we can't remove suffering if we've done A, B, C, and then you can't, we've tried everything. No, it's causing suffering that cannot be relieved in a way the person considers tolerable. It could be, look, how about social work intervention? I find that intolerable. Just saying, I'm being devil's advocate here. So then the other ones are more sort of ruling out things. So you have to have decision-making capacity in relation to voluntary assisted dying. So if you have dementia or mental illness or a disability, that's your only problem. That cannot be the primary diagnosis that makes you eligible for VAD. Being very clear. So dementia, mental illness or disability cannot be the primary diagnosis that makes you eligible for VAD. However, you can have dementia or a mental illness or a disability as a background, and then you, for example, got diagnosed with terminal cancer. And then, so you can have that as a background. However, those things in the background should not be removing your mental capacity to make medical decisions. It's very important. So you have to have your faculties completely. And you have to be acting, well, the first word is V, voluntary. So you have to be acting voluntarily without pressure or duress. Family, friends, other people, doctors, nurses cannot ask for VAD on your behalf. I want to be very clear on that. They cannot ask or get VAD on your behalf. You are driving the bus. Making clear?
For now.
For now. And you have to have an enduring request to access VAD. In other words, I could have said yes, gone through the process, and at some point I've said, nah, I've changed my mind. So I'm not going to force it down your throat.
Yeah.
Okay? So does that sort of clarify who can access voluntary assisted dying?
Yeah.
I've
So
got more information on what the process entails,
Yeah.
just to get rid of any myths or misunderstandings.
It would be important to go into.
Yeah.
Just to reiterate, this is the legislation as it stands in New South Wales. Okay. And it sounds almost, to someone listening to it for the first time, it sounds almost very conservative. It doesn't sound as though it's easy to do. And that's why I jumped in earlier and said, for now.
Other states have had a little bit more conservative. Would you believe it or not, Victoria's actually one is probably
Really?
more conservative, but that's probably because it was the first state
Okay.
to get it in. I'm not going to go into the nitty gritty. There are, but generally they're all quite the same. But yeah,
legislations can change, and it's been proven in other countries that they have changed. But this is what we're dealing with now. Okay.
Yeah.
Please.
So I meet that sort of as a layperson, as a suffering person. I wouldn't know all that criteria. All I know is that I've got a terminal illness and I just want to die, or I don't have a terminal illness and I just want to die. All right. So I make a request, but I make a formal request. I've got to say, Dr. Bejjani, I want to end my life with voluntary assisted dying. Now, it doesn't have to use those words, but I want to end my life formally with euthanasia. And I would say, are you sure that, so you're saying you want something specifically, you want to take something to end your life? Yes, that's what I want. That is a very clear first request. So you've got to make a first request. The tricky thing is, what about the other fairy stuff where I'm suffering and I just say, oh, I can't do this anymore. I want it all done. I want to go. I've had enough. Is that a first request? We're not really sure on that, I'll be honest, but a lot of us as a consensus in our group would say probably not. And it'd have to be a clear sort of first request without duress, without distress, and making a conscious non-emergency decision. This is all meant to be a non-urgent, non-emergency healthcare. Okay, so the patient makes a first request. They go to a coordinating practitioner, sees their first request, and starts actioning. Has an interview with them, assesses them, makes sure that they meet the eligibility criteria, and then sends them to a consulting practitioner. So there's two practitioners. So a coordinating practitioner, then goes to a consulting practitioner. The consulting practitioner does sort of pretty much the same thing, just to make sure that there's nothing's been missed, and definitely make sure the prognosis, or if the coordinating is not sure on prognosis or not sure on capacity, might send it to the but there has to be two practitioners involved. Then the consulting practitioner will say, yep, meets the eligibility. Then there's a written declaration by the patient, a final request, a final verbal request to say, yep, go ahead. And then the coordinating practitioner submits. This is a final review where the coordinator, okay, we've got everything in, let's do the submission. Then after submission, or during that process, the patient in New South Wales makes a choice right at the outset. Do I want self-administered? Do I want to self-administer the substance? Or do I want a practitioner-administered pathway? So you can make that decision at the outset. Victoria is different. Victoria by default is self-administered until you can't self-administer, and then you can sort of change. So it's a little bit different. I'm not going to go into the nitty-gritty, but with self-administered, you actually have the biggest difference between them. There's a self-administered VAD patient. I have to appoint a contact person. Father Ben's my contact person. So you then are responsible for, when I take the substance, to reporting to the coordinating practitioner, will then have to come and do the death certificate and notifying the board and all of that business. If you choose a practitioner administered, then the practitioner is generally would be the contact person, really, because they're there at that time. They will administer, which is an IV medication. So self-administered is an oral medication, and practitioner administered is an IV medication. So that's the nitty-gritty of it all. The death certificate is interesting. So the cause of death is what made you eligible for VAD. So let's say my eligibility for VAD, the diagnosis was pancreatic cancer. So on the death certificate would say pancreatic cancer. There's a new sort of medical certificate, there's a little tick box there that says death via VAD. You tick that. That goes to the government and statisticians, and but it doesn't reflect on the death certificate that the family get. The family would get, death by pancreatic cancer.
Hmm.
So,
Do you know why that is?
probably just to one, confidentiality. Perhaps family members don't know that the patients.
Okay.
There's nothing in there that says everybody has to know.
Yeah.
So perhaps they want to do it without anyone knowing, or for privacy reasons. I think there's probably also so we don't freak people out about, they died via voluntary assisted dying, and no, they died. I think it could be part of a normalization process to say, voluntary assisted dying is just a process. The problem was pancreatic cancer. So they're my thoughts. They're my
That's interesting.
Thoughts and ideas.
That's interesting. So, in the medical field, you will know that this was what happened, but on the death certificate, it'll say.
Well, in the medical field, if you were involved, yes, you would. But if I wasn't told and I wasn't there, and the family members didn't know, they died yesterday from pancreas. Okay, so I would. It goes. I think what they're doing is they will collect the stats. In the background. But I guess they don't want it reflected in the death certificate. So I can't tell you exactly why, but they're my thoughts.
I could be completely off here, so please correct me if I'm wrong. But I found it a little bit interesting that, if a person has a terminal illness, on the death certificate we'd say that that's what it was, like a heart failure, a stroke, whatever it may have been, cancer, whatever. But they chose to end their life prematurely by opting for VAD. Yet we've had for years now, and I've encountered this with a lot of mourning families. We've had people with the COVID pandemic, for example, where it would be the person had a terminal illness, but the cause of death was COVID. And that was very happily recorded. But the person had a terminal illness and maybe had pneumonia at the end or something like that. But because it was a COVID positive case, that's a COVID death. So I find that very interesting that in when you compare those two things, it's like, well, voluntary assisted dying is not going to be the cause of death. They're actually going to record what the person was dying from. I don't know. That's just a bit of a thought
I'll be honest
experiment.
with you. That is a good thought. I cannot comment personally because I wasn't involved in any COVID deaths. So when COVID was around, I was working remotely from COVID. It just so happened that was in the environment that I was in. So I can't really comment. In terms of anecdotally or experience wise. But yeah, it's a good point.
It's interesting.
Well, yeah, because there's something disingenuous about it. Like, I understand. I mean, if there's not really. I don't agree with it, but if the family gets a certificate to say that it was pancreatic cancer, for example, for their sake, okay, but then it's even going to the government and to this, it's going towards statistics. There we go. Still saying that the cause of death is
the mode of death.
Oh, sorry. Yes, the mode of death is because it's saying pancreatic cancer via.
Yeah, so it's it's can be syntax, so it's a bit wordy, but yeah, it's the mode of death. Look, that's beyond. That's the process that's in there. That's sort of any of us.
So in explaining all of this, we've gone into the legislation, what it looks like, how it's administered, who can opt for it. Let's ask that existential question, which I think has been covered slightly. Why might a person opt for this?
So we actually have some data on that. So there's some Victorian data about that. We do have to talk about conscientious objection as well. That's really important for our listeners.
Yes.
But let's answer your question first. So the Victorian data basically is that the biggest reasons, 1, 2, 3, 4, 5 reasons, the biggest two reasons are loss of autonomy and loss of ability to enjoy activities. So It's that existential defunctioning. I can't do what I like, and I can't be independent, and I'm not who I am. This is not dignified. This is not fun. I'm not enjoying my time, or I'm not comfortable. There are illness-related suffering like pain, so that does come, but it is actually sort of a minority. Interesting enough, there's a fear of future suffering, so they might not be suffering now, but the fear of the future suffering could be from past experiences, could be from literature, who knows. And no, I don't want to die like that, and that fear is causing me suffering, so I'd rather be in control. And again, previous negative experiences around death or dying, so you're projecting that sort of experience on what this is going to happen to me, or high risk of happening to. I don't want that to happen to me. So as you can see, there's not a lot of pain, and there is a bit of that there, but there's a lot of other existential stuff going on in the background. A lot of other existential stuff, and that's mirrored with a lot of anecdotal evidence from other states as well, to say that the least amount of patients that ask for VAD is because of terrible physical suffering. It's actually the existential stuff, the distress, the demoralization, the depression, the anxiety around death and dying, and the fear around it.
And look, in my very short-lived pastoral experience, I can, in saying that, I can identify that there are very gifted people out there that can help with things like that. A lot of those existential questions can be talked through. It involves relationship with another person. It involves giving them the gift of your time and sitting with them and talking to them.
Well, that's exactly what I do as much as I can possible. And I just want to be clear, I'm not this hero or this, but, I try and see the need, and look, I'm not a trained psychologist or a counselor, but I've had some life experiences, and I guess I can relate well to patients. And so I just, you always grab a chair and you sit down and you just, what's going on? Tell me more. What's happening? Tell me about your life. Tell me what makes you tick. What did you used to do? Wow, you were born in 1920s. You must have grown up in the war. How was that? Oh, you're from Poland, or you're from this. So how was it like emigrating? How was it? And you just, wow, you realize, honestly, this is probably my favorite part of the job, if I'm not too stressed in the background with time pressures and all that. But everyone's got a story. Everyone's got a story. And only God knows it to its fullness. And you realize, wow, this person's story is what's led this person to make these decisions in life. It shapes your decision making. It shapes your worldview. It shapes your spirituality. It shapes your psychology. It really does. It's wow, what a story. And then you realize, wow, you've suffered much. You've really gone through a lot. And look what you got around you. Look at your family around you. Look what you've achieved. Look at this. And we're very happy to look after you. Don't worry about any of that burden stuff. This is what we do. And on the question of burden, it's there's a lot of more so elderly. The young ones do it too, but sort of like, I don't want to be a burden on my family. Like especially men. Like I exist to provide for my family and to support my family, and now I'm asking them to support me. I don't want that. This is not me. And then you just say, if the tables are turned, God forbid, and that's your wife or your daughter or your whoever sitting there, would you think they're a burden? And 10 times out of 10, I'm not going to say 9, 10 times out of 10, the answer's no. And there's no response. There's more, I'm like, well, therefore you're not a burden, and they are so privileged to look after you, and so am I. That's where people just have to, it's not about drugs and pay. I mean, that's important too. But it's the person.
Yes,
it's the person that's forgotten in the middle.
Amen.
And who is the person? We're made in the image, and like that's,
Yes.
when you did it to the least one of these, you did it to me.
Amen.
That's the person. And so it's a bit of a mission of mine. It's a bit of a calling. And I try and do it as best as I can. I'm not perfect by any means, and I've got great people around me.
You said you're not a hero. In our eyes, you are.
No, what?
No, in our eyes, you are.
No,
Because
I'm so far.
Allow me. In your field, in just in the medical profession itself, this is almost a vocation within a vocation. This is something and you can correct me if I'm wrong on this, this is something that not all people in the medical field look at, because as you said before, they're targeted. Might be heart, might be throat, might be, you know,
And I don't
cancer.
expect them to, like, you know,
Yeah.
it's
But this is like we've used this word, and we're using it in the correct sense. What you do is holistic. You're looking at the person. You're looking at the human being before you. And that is all, whether you're a doctor or not, a priest or not, it doesn't matter. We're all called to recognize the dignity of the person that we stand in front of.
Yeah.
Imagine the world that we live in today if everyone took that approach.
If we took it, if we were celebrated for it. This is the thing, because positive reinforcement is really, really important. If you're, you know, you're rewarded for KPIs, you know, how many numbers and all that, you know, palliative care does not reflect well on numbers, never. So we are all about qualitative stuff. We are not quantitative stuff. And look, it's I've just been blessed with a Christian and Catholic upbringing, and just trying my best to put that in as many facets in my life. I mean, I fail horribly everywhere, but you know, you pick yourself up and you're like, okay, well, you know, I'm going to say a word. Can I say 2 Latin words?
Say it.
Nunc cepi. A new beginning. Every day, every hour is a new beginning. Stop worrying about your failures. Get up and go, because your failures put you down, and you look at, oh, I can't do it, and you never move forward. But stop that. God will forgive you. You got to forgive yourself. Move on.
So let me ask you this question now. You're a practicing Catholic.
I guess so. Yes, I am.
We all we try our best.
Yeah.
But no, there's a faith in what you're doing, and you're bringing this beautiful gift into the medical field. They've now passed this legislation. I think this is a good segue into conscientious objection.
Yeah.
So talk to me. Let our viewers and our listeners know what that is.
Yep.
And how you go about that.
Yep. So in the legislation, there is a clause very clear about personal or individual conscientious objection, and any clinician can conscientiously object to be a part of any part of, like, the entire process. You can say no, thank you. And in fact, the legislation went one step further, and I think this was a minor amendment of sorts, because I read the first version. The second version was different in this, and I was going backwards and forwards. I'm not a lawyer, by the way, but legislation is a bit interesting. So if a patient comes up to me and says, I want VAD, just keep it simple, I can say, no, I'm a conscientious objector. And I can say, I cannot help you with the process. I'm not obliged to actually refer you to anyone. I'm not even obliged to give you any information booklet. I'm not obliged at all. But I can't stand in your way. And I think that's fair. I mean, we can't stand in anyone's way. There's a freedom, and God gives us freedom to sin. Yeah, He doesn't want us to, but we have that freedom. So we can't stand in their way. What I do have to do, though, an obligation, is I then need to report that. So I need to write that in the medical records, depending on where I am, as an inpatient or in my clinic or whatever. I need to write that in the medical records. Then I need to actually formally report that incident. So every single request needs to be reported to the VAD board. Every request, whether it's granted or not, whether it's whether I'm taking it on or not. So I'll say Joe Bloggs requested VAD. It was denied because of conscientious objection. So I have to write that. And then I submit it. I've got to do that within a couple of days or so. So every time somebody formally, it's quite a burden of work. Every time someone formally requests VAD, I have to do that. So I'll say, no, I'm a conscientious objector. This is obviously just being very formal about it. I'm not obliged to give you information. I'm not obliged to send you any. You can Google it yourself, really. And then I go and do my I got to submit that request and the denial to the board. I don't know why that's that, but it is the way it is. That's individual conscientious objection. Where it gets hairy is, and I'm not an expert on this, there's somebody else in the diocese who knows more about this, but it is institutional conscientious objection. This is where it gets quite dicey and a little bit more difficult for faith-based, Christian, Catholic, and other faith-based institutions such as nursing homes,
Yes.
hospitals, where the ethos will be, let's just say let's say a Catholic nursing home. We want to uphold the Catholic ethos of, upholding life from conception to natural death. But I've got this resident who, this is their home. This is actually their legal home. I can't boot them out. No, unless there's, funny criminal activity, but this is their home. They've asked our clinicians, nurses and doctors, they want voluntary assisted dying. They're personally not obliged, but the institution themselves cannot stop other external suppliers or external providers coming in and assessing, doing their assessments. And I don't think we can legally stop the current resident actually committing VAD or doing voluntary assisted dying on the premises. Don't quote me on that. So I want to be very clear. I'm not a lawyer. So I understand ways around that legally. That would probably be another forum. It's beyond my expertise to comment on that. It's very clear about the individual, but the institutional one is going to be quite difficult to navigate. That's relevant because a lot of palliative care is provided by faith-based and non-government organizations in affiliation with the government. So they're government funded. There's a third agreement or second order agreement. I can't remember what it's called in the legislation. But they are a faith-based institution with an ethos, and everyone will just have to come up with their own way of addressing it. I'm not sure what I'm not sure what the Archdiocese has, because there's a lot of Archdiocese-based care institutions, hospitals and nursing homes and other things. So I'm not sure. I think you need to get somebody better to discuss that than me, but that's my understanding. And I would encourage the listeners to do their own research and speak to better equipped people than that. Yeah.
And we'll put the links to those pieces of legislation and all sorts of things in the show notes. So we'll get that done.
But for me, I have no shame, and I'm very clear to still tell my colleagues, junior and senior, guys, I have no shame. I'm a conscientious objector, and I don't have to say because I'm Catholic, because it's not because I'm Catholic. It's because I uphold life. It's part of my Catholic upbringing, but I just don't like the notion of falling back on a religion to say this is why I don't want to do this. No, it's not because my religion told me to, like a little boy.
Yes.
It's because I subscribe to this religion and to this faith because I agree that we have to respect life from there to there, and it just conforms to what I think is truth.
Yes.
To what is truth. Yes. Does that make sense?
Yeah, it does.
And if people want to inquire, I'll talk about church and the Catholic Church and everything. That's my approach.
Look at the number of patients you've looked after over the many years you've been a doctor. The proof is in the pudding with everyone that you've been serving for all these years. It's like this, you don't need to fall back on the religion to uphold what you've been doing. And just as an observer, it seems as though VAD just undoes all of that beautiful work that dignifies that person that you're treating in the moment. It's like you are getting to know them. You are reminding them about the dignity of their own life. You're reminding them that they're loved, that they're wanted, they're valued. You're giving them different perspectives, ways to think about things, because you're spending time with them and caring for them. And then we, as a state, pass this law, and it just undoes that.
I feel like it's going to be a distractor as well. Look, and sometimes it could be, there could be, I'm going to be careful with this word, blessings. There's always a silver lining, isn't there? There's always a greater good out there when we introduce evil. That's God's doing. But it's now we're having this discussion about preparing for end of life. We're having a discussion about palliative care, but also it might be the segue for the patient if they start talking about VAD. Well, that could be then talking about their end of life care journey and their advanced care planning, and then that could fizzle out. But my concern would be other clinicians or other people might say, "Oh, this person asked for VAD. We just focus on VAD," and we don't, and we it's a distraction. Where the real problem is why are you asking about that? What's going on? Can we help in this way and that way? What's the real? Do you like if you had an option? Would you really? You know what I mean. So
Yes.
perhaps not everyone's going to take that path. That's quite individual.
Yes.
One thing I do want to say clear in the legislation is you clinicians, doctors, practitioners cannot suggest that as an option for healthcare on its own. However, we are allowed to, by law, suggest it as an option as long as we provide all the other suite of options available. Chemo, radiation, surgery, palliative care, best supportive care, VAD. That's allowed
Yes.
legally.
Yes.
In other states, you are absolutely not allowed to. In other states, you can just mention VAD on its own. So it's a bit of a hodgepodge there. So it's going to be an interesting thing to watch. Yeah.
I want to just bring the conversation back a little bit to what euthanasia actually is, just to get some clarity on it.
Yep.
Is it just a lethal injection, or can it be other things? Can it be, yes, actions that are done, such as a lethal injection? Sorry, yeah. Or can it also be not doing something like
Withdrawing from treatment.
yes.
Okay.
Yes.
All right, you're opening another door here.
Yeah.
Okay.
Should we do the
Yes,
catechism
I think
first?
there is the second part
Oh,
there.
cool.
So let's talk about what the church teaches, and then Charbel, you can expand. This is paragraph 2278. It says, discontinuing medical procedures that are burdensome, dangerous, extraordinary, or disproportionate to the expected outcome can be legitimate. It is the refusal of overzealous treatment. Here, one does not will to cause death. One's inability to impede it is merely accepted. The decisions should be made by the patient if he is competent and able, or if not, by those legally entitled to act for the patient, whose reasonable will and legitimate interests must always be respected.
Yep.
So do you want to explain?
Yeah, this is nuanced, guys. So this is on a case-by-case individual thing. So there are, I guess, let's start with this. The two words that I like to use, futility and burdensomeness, or something that is burdensome. So futility means this treatment is not working. But it may also mean, on the balance of things, this treatment is extremely unlikely to work. So we don't have to try every single thing under the sun. We can say, look, that's unlikely to work. And we know this one from either statistics or evidence-based medicine, but also experience. Then there's the flip side of burdensomeness. So something could be possibly, this treatment is not futile. It could have a good chance of working, but it is extremely or it's burdensome, and it's detracting from what we call quality of life or from living. And Pope Francis calls it two things. There's something of treating illness as opposed to promoting health, treating illness as opposed to living. Now with modern medicine, that is being teased out quite, I guess, with a lot of difficulty, because we as Catholics, we want to treat to the end. And in fact, a Catholic came up to me last week and just said, doctors have to treat you until you die. In a way, it's true. I have to treat you, but his understanding was you got to treat my cancer until I die. That's not the case. We have to offer treatment that's likely to work and that's not going to be burdensome. Okay. The other thing we use in medicine to talk about futility and burdensomeness, because they're quite theological things to talk about, although medically they're understandable, is risk versus benefits. So often you have doctors that will say, surgeons or whatever, will talk about these are the perceived benefits and these are the likely risks. If the risks outweigh the benefits, then we're not going to offer this as a treatment, or we offer it with severe caution to say we might trial it for a day or two. But if there's no benefit, or if it causes more harm than good, we need to stop it. So that is, I think that is completely within good theology and good Catholic healthcare, good Catholic care, good Catholic doctrine. Now, withdrawing treatment. So patients could be on dialysis for some time. And dialysis is quite we just live with it, isn't it? But it is quite an extraordinary means of what we call renal replacement therapy. So you're just literally replacing your kidneys because they're not working. Without it, you will die of kidney failure at some stage. It might be minutes, hours, days, weeks, months. Very hard to tell depending on the situation.
Yeah.
But treatment with dialysis can become so burdensome. All right? 3 days a week hemodialysis, or every day peritoneal dialysis, or I'm coming into hospital weekly, monthly because of a dialysis related or a kidney related problem, and I'm just bouncing in and out, and I'm not really living. This is, God doesn't call us to, this is what I think, not a theologian, but God doesn't call us to have to stretch our lives to every minute so that we bounce in and out of hospital. I don't see that as good Catholic living, I'll be honest with you. In fact, sometimes I wonder, are we God's calling us and we're saying, go away, no, I want to, I'm putting it out there. I'm not a theologian. I'm just, I'm a cat amongst the pigeons, so to speak. So they can come up with the decision to say, I would like to withdraw this, what I perceive as an extraordinary means of staying alive. And that's kosher. That's okay. Sometimes that could be feeding and fluids. It's very few times. But at end of life, and there is a big Catholic hang up about feeding, so nutrition and fluid at end of life. The ethic books, catechism are very clear. We must sustain life as much as appropriate, including fluid and feeds. But if someone is in or approaching terminal phase or is approaching end of life, feeding and fluids are not only futile, because they're not fixing the problem, they can be burdensome and cause harm. I'm not going to go into the nitty-gritty, but often that's a discussion that I have with patients and families. I don't wish the hastening of anyone's death. And in fact, when we withdraw this feeding and fluids, patients don't die like this. The body's got an amazing way of actually managing its own nutrition and fluids. It's got reserves. It's an incredible machine, the body. And we do not intend that person to be dying by dehydration or by malnourishment. Now, if I withdraw feeding and fluids from you, you will die of malnourishment and of dehydration because there's nothing wrong with you, I should hope. All right? You are well. You do not have a progressive advanced terminal illness. Does that make sense? Yeah. In fact, those with progressive advanced illnesses, I would like to say 100% of the time, but let's not be absolute, 99% of the time, don't want to eat. They don't want to drink. That's their body winding down. That's the winding down process. And if we force it, we actually can cause more harm. The body rejects it in different ways. We can possibly cause more. Very nuanced though. Don't go and say everyone dying shouldn't have anything. Yes. It's very particular. In some cases I say, no, this person is actually not at end of life and actually needs fluid support now. We need to get support because they're not dying. They're not in the background dying. They've got a terminal illness, but they're quite early stage or mid stage and they've got an acute problem and we need to support that. In fact, some of my colleagues or other people might call that aggressive palliative care, but it's not. It's actually what is appropriate to that person given their circumstances, their medical and other. Yes. Does that make sense?
Yeah. So can I just add on to that? Just a follow-up question. So at what point does withdrawing treatment turn into, I guess, a passive form of euthanasia?
I'm going to give a very general answer because I have to.
Yeah.
If the person in front of me does not have a progressive, advanced illness that is going to shorten this person's life, clearly, then I don't think withdrawing appropriate feeds and fluids is right. I'm being very general because I can't be specific.
Yeah.
So it all hinges on what's the primary problem of this person. Now, you could have very mild to moderate dementia, and we want to continue feeds. But as dementia gets worse, you just eat less and less. You also might have problems with swallowing. That's part of the neurodegenerative disease. We know through studies that force feeding with nasogastric tubes doesn't actually, or PEG tubes, doesn't really change outcomes of things. In fact, it causes a lot of harm, potential harm, but also actual harm and burdensomeness, because it's a device. It becomes now a device. They can pull it out, it can get infected, it can get blocked, then it's going in and out of hospital. So in those cases, we're not withdrawing feeds and fluids. We're still offering, like, sorry, I talk with my hands a lot. It's, you've got dementia, I'll offer you, if you can't eat and drink, because of that progressive advanced illness, then you need to let nature do what it's doing.
Yeah.
Yes.
As opposed to, I'm unconscious because I have an acute or a sudden infection and I don't give you fluids. Well, that could be, it's not really passive euthanasia, it's just poor medicine, really. In terms of, I need to support your life with fluids. But fluids is a support, it's a building a bridge to somewhere. Fluids in and of themselves cannot support life to the nth degree. In fact, at end of life, it causes problems. It starts what we call third space. So it goes into areas we don't want it to go. Lungs, skin, in the abdomen, and it causes more problems. So but this is that pointy end of life,
Yes.
But if there is life to sustain, if the body's, see, people think we heal people. Often we don't. We support life until the body does its job. Or we get rid of antibiotics, so we get rid of the infection so the body's immune system can do the rest. We get rid of that really, really bad hump. That's what ICU is all about. That's what medicine, a lot of it is all about. It's, we might cure sometimes, but the vast majority of it is we do something so that the body can then take it from there. It's like passing, here's some sport, passing the baton, passing the footy, all right? Yeah. Sorry about that, no footy today. But if the body cannot, because of an advanced progressive illness, or it's reached a point where the body's now heading towards that terminal state, and the body can't support itself, then I am under no obligation to support it artificially. Because the body's heading down a one-way road. What I need to do, though, is look after the person. So give good care. Give good end-of-life care. Does that make sense? I might be offending some people.
No, it's
and it might be a sore point for a lot of patients, and I don't mean it to be. I'm being very frank and forward. So I hope. You
said that death and dying is ugly.
Yeah, it is.
And not only is it a disturbance for the person going through it, but also a disturbance and a tension for the loved ones. I just want to quote this final paragraph under euthanasia in the Catechism 2279. Even if death is thought imminent, the ordinary care owed to a sick person cannot be legitimately interrupted. The use of painkillers to alleviate the sufferings of the dying, even at the risk of shortening their days, can be morally in conformity with human dignity if death is not willed as either an end or a means, but only foreseen and tolerated as inevitable. Palliative care is a special form of disinterested charity. As such, it should be encouraged. So the word that really struck me in that paragraph was ordinary, the ordinary care owed to a sick person. And so people, a lot of the time, on this issue of feeding and hydration, and this patient you've had, treat me until the day I go, is that ordinary care?
So I guess the Catechism writes it so beautifully because it's a rule for the ages, isn't it? So it's a rule for all worlds, third world, first world, this medical system, that medical system. Because what's ordinary in Sydney might be not ordinary in the Philippines or in the Middle East or even in America. We could have different ordinaries. But the basic ordinary I find is good, what we could say dignified care. The patient's clean, presentable, looked after, not neglected. I think that's really important. There comes a point where, in my experience, forcing nutrition and fluid becomes extraordinary and it's doing nothing. Now, we don't always have to try it. This is the thing. We don't always have to put the patient through so much suffering in order to, it's not working or it's causing suffering now. If I really, on the balance of things, say, in my experience, in what I know from evidence-based or from literature or elsewise, this is going to cause significant amount of harm for very little benefit. Going on talking about the catechism is quite specific on sort of painkillers. Now, we do not practice let's just increase morphine to kill someone, honestly. At least in my training and in my circles and in our discipline, we do not do that. We want to appropriate our medications, our doses, our interventions to the person in front of us, to their needs. Sometimes that does mean, though, rather than being reactive, I want to be proactive. And again, in my experience and knowing what's happened in the last few days or reading the story in the last few weeks, I'll say, I know where this is heading. And rather than waiting for him to every hour get distressed and we give him extra, I'm going to increase the regular by this much to prevent this person being in this distress. Now, we always have that in discussion. If not with the patient, if they're out to it, then we have that discussion with the loved ones there. And a lot of it is a medical decision, but I often want the blessing of the family and the people around me. This is what I want. This is a medical intervention. I'm the expert in this and my team are the expert in this. You, I guess, can suggest things, but you can't sort of tell me. It's like taking your car to a mechanic and saying, I want my timing belt changed. And it's like, well, but it doesn't need to be changed, but I want it. But no, your problems are your brake fluid. No, but I'm telling you that this, it's the same thing with medicine, is that we, good medicine, which I think there's still a lot of, and good medicine is, this is our expertise, this is what we offer you. You can refuse it, and if you do, tell me why, or we can go for it together.
If you don't mind,
yeah.
I have a question based off of a personal experience.
Well, that's if you don't mind.
Okay, I'm okay.
Okay.
Thank you. So I was telling you before we started recording, you saw a photo of my dad, and I was telling you he passed away in 2016. And now my dad was on his deathbed. Thanks be to God with all his family around him, which is a beautiful thing. And he was given a dosage of morphine in his
terminal stages.
Yes,
yeah.
Terminal stages. Thank you. And then we just noticed that he was in a little bit of discomfort or pain, and obviously just wanting him to not go through that in his last moments. We asked the doctor if he could give him some more morphine, and we were told that he couldn't give him any more morphine because it would be crossing a line, which to our understanding is, I mean, we didn't. It was solely for the purpose of Dad feeling comfortable,
giving Dad comfort. Yeah.
But if that was if that was saving us from euthanizing our dad, then
you felt comfortable with that decision.
Yeah, we were comfortable with that decision. Is there a point there where giving him more morphine would have been euthanizing?
Look, I'm going to be technical now. Morphine's a terrible euthanizing drug, okay? So I'm just going to say that. Opiates are not, like, unless I give you a big whopping dose of heroin or something like that, or a big whopping dose of morphine which you've never taken before, yes, that will cause an issue. But often patients at end of life have got extreme amount of symptoms, whether it be pain or shortness of breath or, work of breathing, and their body can take it. And often we start at a low dose and we go up and up and up. So the body starts to tolerate the dose. Look, without knowing the details, so I can't judge this doctor or what happened to your dad, but I am quite sad about what that doctor said, because if Dad was uncomfortable, then we weren't meeting his needs, and something needed to be done. And if the goal is that we want to make sure, if it's clear, Dad's dying, all right, time, no one knows time except him, but his path is very clear. He's spiraling down. Yeah. And the only thing we have control over is the comfort on the way. And he's uncomfortable. Now, if he was purely comfortable, and then you call them someone and say, I want him to have morphine, they'll go, that'll be why he's fine. And I would actually question saying, no, I don't think he needs it. That might be crossing a line to say he doesn't need it. And I've had very rarely, I've had those sort of discussions with family members. Oh no, they're uncomfortable. And you look at them like, no, they're comfortable. I think you're uncomfortable. I couldn't say that to one of them, but in my mind I was like, I'm treating you, not the patient.
Yeah.
But in that case, you're telling me Dad was uncomfortable, he was distressed, and
at least from what we saw, we're not medical experts.
Yeah, but I have to say the carers are the most important people. When I go in there, I might be with the patient on my ward rounds 5, 10, 15. Let's call it half an hour if I'm generous, all right? And I've got the time. That's half an hour of a 24-hour day. There's 23 and a half hours left that I'm not part of, and I don't see what's going on, and I don't know what the ebbs and flows and the roller coaster is like. So I rely on history. I rely on the nurses that are there for 8 hours shifts at a time, but often I rely on those who are there, the carers, and I direct the history and the questioning to say, well, tell me about the distress. Tell me about what's happening when it's happened. Tell me, how does it look like? What are you doing at that time? What helps? What doesn't help? You help me to help you. Okay, so it's a partnership. It really is.
Yeah,
it's cricket. Sorry, it's not footy, but anyway. So sorry, I'm not making light. But
no.
Look, it's so without knowing the situation that your dad was in, but you know, I if he was distressed and you're telling me he was, and I would have to trust you on that because you're a loving family, then I would have said, sure, let's see what more comes. Or you do a proper assessment on a patient. So you do a medical assessment or a nursing assessment on the patient. Take back the sheets, examine the patient from head to toe. What's going on? Could just be full bladder. The patient needs a catheter. Could be full rectum. The patient needs to evacuate. They could be in a very bad posture or position, or have been on their back for 12 hours and just need to reposition. Could be as simple as that. Okay. Or it could be the physiology is winding down and death and dying are taking their toll, and the body's becoming toxic and the breathing, comes up, or there's more pain because if it was a cancer, the cancer's progressing or other problems are happening. So, yeah, I think that's quite tied in with that one from the catechism there.
Yeah.
And I guess that ties in with, for those theologians out there or theological buffs, the principle of the double effect that Thomas Aquinas sort of talks about, and I guess people before him as well, where you're doing this for this intention with the knowledge that it has risks to cause this, but that is not the desire. That's the double effect.
Yes.
That's the second effect, which is completely undesirable. I don't want this effect, but without this, I can't do what I need to do without risking this.
Yes.
And it's got to be very, again, what did I say? Palliative care is very nuanced, practical business. So it's really case-based. There have been many ethical situations that I've been involved with, patients at end of life or patients with terrible symptoms, and I'm going into territory that's either very rarely trekked or very dicey and very tricky. And the last thing I want is to cause the death of someone, but the last thing I want even more than that is to see the distress that's in front of me now, because what am I here for? And I'm not, when I act as lone wolves, I grab the phone and we have discussions with colleagues, we have discussions with people, other medical colleagues. I've got a very good sort of Catholic network of very good ethical, practical doctors, but also I might sort of speak to somebody, a priest or a theologian in the area, it's so hard to make those decisions, very hard to make those decisions.
Yeah.
So yeah, there's a lot of weight and gravity there.
Yeah. Well, that's an an interesting answer. Thank you for that. It's good to know, just for myself. I know very little, but it's good to know that, it probably wouldn't have done any damage and things, but I know that for not for next time, but
hopefully
I know
not
that from now. But
look, the other thing is often with physiological stuff, so with suffering, distress, pain, and the other things, it does cause a stress response in the body. And I'm not talking about, I'm stressed about life. a proper stress response, sympathetic stress response. You know, there are stress hormones involved, there are other hormones, heart races fast, the lungs start to breathe fast, you know, you feel yuck. It's like, just think of a panic attack. You know, they just come out of nowhere, but you feel terrible. Now, that could be caused by pain or other symptoms. By increasing the medication or introducing a medication that helps to treat the underlying problem of the distress, reduces that distress, reduces the physiological stress on the body, and there is a theoretical advantage to say, well, this could actually maybe prolong things a little bit as well. There's a little bit of small amount of data out there, particularly with shortness of breath and respiratory distress. When we reduce that distress with increasing amounts of morphine, that can reduce energy expenditure, it can reduce lactic acidosis production, it can reduce that physiological stress on the body that can actually have positive influences on life. And no one's ever really going to know, because we don't go around experimenting on dying patients. Some people have, ethically, but in modern times. Yeah. But there is, and anecdotally, I do see that. I increase something, and I thought this person was going to die today, come back tomorrow, wow, they're calm and comfortable. And I just say, am I prolonging their death, you know, their dying phase? And we have this thing that we say, you know, prolonging the dying phase. That sometimes even giving fluid or other things or antibiotic, it's futile. We might be extending things by days, but we're just extending the dying phase. We're not really contributing to life, to actual meaningful life.
Yeah.
Again,
look, it's
very, very dicey, I know,
yeah.
when you hear it like that, but when you're on rounds with me and you see what we do and how we make these deliberations and decisions, it kind of makes sense.
And I think that's key. No one is on rounds with you, and that's the beauty of what's happened this afternoon in our filming of this, because I think you've given us all an insight into that very kind of niche and very technical care that can be given to someone that has a terminal illness, and we can respect their dignity. And I mean, even for myself, I've seen families come together that have been, you know, feuding, and they've come together because their loved one is being looked after and cared for, and they have been the means of a family reconciling. That's just one example among many. Yeah. But the reality is, we can do better. We are doing better. And I mean, I'm not apologetic for this. I don't think this bill in any way supports the dignity of the human person. The church backs that up. For anyone that wants to read more about this, the Catholic Weekly, and we'll put the links in the show notes, wrote about what was going to happen, the pastoral implications for us as priests, for people around this VAD legislation. And it's something I think after today, this is an episode you will watch. I hope you will rewatch and then watch again and think about these things. Think about having these conversations. Look more into palliative care. Read more, question more as to why the church teaches what it does, the dignity of human life, and how we as human beings are supposed to look at the person in front of us and say, you are worth so much more. And I think we as a society, as a culture, we start to fail when this is the best we can come up with.
Yeah. It's funny you said that, because my registrar last week was speaking about a patient, and we actually called it, there's a bit of social failure here. It's not heart failure, it's not brain failure, it's a bit of social failure. And it wasn't a VAD case, but it was quite a sad, there's a bit of social failure here. Yeah. And how do you manage that? Not with a doctor, I can tell you that. Yeah. You manage that with governments, executive, with family, with just listen to the church. Have a good family.
You manage it with love.
Thank you.
You manage it with love.
Thank you.
Sorry. I just want to add, every time I've spoken with someone about euthanasia, and I do find it one of the tougher things to speak about, because there's a lot of emotion and things involved in it, and typically the word compassion comes up. And it's, I mean, the first time I heard about euthanasia, I was in year 8, and my teacher, my Catholic studies teacher, Mrs. Pinto, God rest her soul, she brought it up. And the first time I heard what it was, my initial thought was, well, that's just wrong, because you can't just kill someone. It's not your life to take. Like, life is a gift, right? And who's it given by? It's given by God. So I thought, my initial thought was, well, only God can take it, right? And firstly, Father Ronnie once said to me that when your argument for euthanasia or for abortion or for any ethical issue is solely based off of your faith, it's not invalid. And I thought, okay, well, that's good, because that's where my initial thought was, is that it's solely based on my faith, is that God is the author of life. We can't take it, only he can. And he said to me, it's just as valid as the logical or the reasonable arguments that are made. Now, as a Catholic, it's just as true to me as all the other logical and reasonable truths are. So that was beautiful to hear. But then I'm also someone who likes to go through the logic and the reason as well. So I did. And anyway, sorry, to go back to what I was saying, it's always dealt with emotion, or at least most of the time. It's dealt with emotion, and people say, well, I don't want the person to suffer and things like that, like we've mentioned already. I just want to speak into my personal experience just a little bit. Now, I haven't been at several deathbeds, but I was there for my dad. And I, just from that experience, I could just see, and I know that my dad wasn't worried about any discomfort, physical discomfort he was going through, or any physical suffering. The only thing he cared about was that my mum was next to him at the deathbed, and that his family was around him. And he received the sacraments, and it was really beautiful. We had both Maronite and Latin right there. I always say, just in case God favors one over the other. But
having a bit each way.
But I could really see that that's all he cared about. And to be honest, when we say dying with dignity, that is dying with dignity. That's having your family around you and having received the sacraments, which was beautiful. And then on top of that, to just go without fear is beautiful. Which
I think that's really important, and that's what our faith can really give us. And the Hail Mary, the last line in the Hail Mary.
Yes.
Pray for us, not at the hour of our conception, although that probably should happen, but not at the hour of when we get married, although that probably should happen. But it's not at the hour of our death.
Yes.
And when I sort of think about the decades of the Rosary, just looking at the traditional fruits of the mysteries, when you get from, just learning them as I was a kid, you've got the fifth sorrowful mystery, which is the crucifixion, and the fruit of the mystery is, one of the fruits is a grace of a holy death, and the Assumption of Our Lady is the grace of a happy death. That's what we are aspiring to, a happy and a holy death.
Yes.
Not because death is the end, but it's because it's the gateway to, I guess, the beginning, isn't it? Yes. And that's what our faith offers us. It's just absolutely beautiful. Amen. So thank you for sharing that, man. That's it's not easy to share.
Of course, no, I mean, yeah. Look, it's something that I know that I never really thought about, but I had a week to really consider the possibility of my dad's death, which really helped myself.
Time.
Yeah. But I do just want to say, just to anyone who goes through it, I mean, I did find it tough. Like, I didn't go through it perfectly. Father Ben at the time wasn't a priest, but he was around our family at that time, as he has been for a long period of time. And I don't know if you remember, Father, but I didn't want to cry in front of my family. At the point, it was a little bit after we were told that he was probably going to die. And I sort of took you to the side, asked you if I can speak to you in private, and then we went just on our own. And a lot of what I I mean, I was upset that my dad was going to die. And my biggest fear was probably, it still is, I guess, going through life without him physically here.
It's a loss.
Yeah, that's right. And it's normal. And I remember telling Father that, and he was reassuring me that it is normal to feel that way. But a lot of what I was remembering about my dad wasn't him in the circumstance that he was in. I remember telling you, Father, a lot of what I was remembering was all the sacrifices that he made for us.
Wow. And
like just how good of a dad he was. And I remember, sorry, getting a little bit emotional, but I remember I walked out of the room when he was taking his final breaths. And I said, I can't watch it. And I had a mate with me. Thank you, Greg, for being with me. And he was outside and he said, it's okay. Like, he was really supportive. It's okay. You don't have to be in there. I know it's hard. And it is hard. Like you said, it's ugly. But then I thought, no, like, that's my dad. I've got to be with him in his final moment. And so after a few minutes, I walked back in, and it was the most beautiful thing to just be there and watch him take his last breath. Wow. And to see his soul, as soon as he passed away, I knew that second he's not there anymore. And his soul had gone up, and I was like, there's a certain separation there, and it was a beautiful moment. But it's just to let people know it's okay to struggle through that time. I don't think anyone really goes through it perfectly, but it's okay to grieve, to be upset, to want your family member, whoever it is, your loved one, to be comfortable, to be whatever, but also to know that there's a beauty in death, and there's a beauty in being around that person and supporting them, and to be truly compassionate, which I know, Father, you mentioned last week, and I heard you, Doctor, talk about it in when you did a talk, or when you were part of a panel for euthanasia at St. Felix, to suffer with the person, come with passion, suffer, to suffer, I believe. So there's true beauty in it, and it's so much more than just rushing it or dodging suffering. So it's just for anyone watching. There's true beauty in it, and those moments I don't necessarily. I mean, I miss my dad. I cry every now and then, but that moment where I watched him take his last breath isn't as much of a sad memory as it was a beautiful memory. To know that, there is something. There was a certainty in my heart the moment I saw him take his last breath, that there's something more than this life. And so
he was well prepared. He got the sacraments. He had his family around him.
Yeah.
It was tough, but you brought beauty to ugliness. You guys did that.
Yeah, well, through the grace of God.
You and the family did that.
Through the grace of God.
Yeah, but you could have rejected God's grace.
Yeah.
Truly. So this is what I'm saying, is the most important people are the carers and the family. Yeah. These are and it's up to us to support you in that sort of very tip moment.
And I think, just to add on to that, Anthony, thank you for that sharing.
Thank you.
No worries.
Your journey as a family in faith brought you to that moment. We spoke earlier in the show about being prepared for these things, and you can't really ever be prepared, but by self-denials, by sacrifice, by looking to Jesus on the cross, your family was in that moment. You're there on Calvary in that moment right there. Yeah. And it was true compassion that you decided, I don't want to alleviate my own suffering in this moment. I want to go in there and suffer with my Father too.
Yeah.
And that's what you did. You actually went in there and you slogged it out. And the whole family was with him. Imagine the peace and comfort that brought him in that moment as he took his last breath.
Yeah.
God rest his soul. And thank you for sharing that.
No worries. To quickly say, I didn't share that story for just as a sob story or for pity or anything.
Not at all.
The reason I share that story is to say that the emotion that comes with the arguments for euthanasia is actually not, it's not the actual emotions you feel in the moment. And I know some people do it out of, maybe not outside of logic. I guess they're thinking a little bit too emotionally, but the emotional aspect that comes with death actually supports the arguments against euthanasia. So that's the reason I share that story.
Yeah.
What a witness. That's
Thanks be to God.
Thank you. That's wow.
Thank you for the work you do. God bless you.
We would like to give you the last word. Is there anything that we haven't covered or something you think is important? What would be okay, here's a question. What is a message you would give to those families currently going through it with a loved one when now this legislation has been passed? Just as a word of encouragement to them, what would you say? Based on your experience, because you have a very unique experience that not a lot of people have.
Yeah.
And we want our viewers and listeners to hear about this.
I say this to a lot of my patients. Look, I say a lot of things, but I think keeping it nice and generic is, and we're talking like, what's the context? Are these people of faith? Is it obviously sort of watching
Speak
this?
to anyone and everyone.
Anyone and everyone. Okay. Whew. I think remember that you're loved by God, first and foremost, by the heavenly court, but you're loved by your family. And just as much you want to care for them, they want to care for you, and accept that in all humility. That's a humble thing to do. Focus on living as best as you can. The things that you can't do, don't bang your head against that wall. You just create more pain. Turn around and look for another angle. If you don't trust a certain practitioner, by all means get a second or third opinion. But don't chase a grail that doesn't exist as well. You cause yourself more distress. So certain amount of surrender as well. I think that's really important. And inner peace. And I guess if you truly are at that point where, okay, there's nothing that can prolong my life anymore. There's nothing that can treat this problem. We're only going to treat symptoms and perhaps a few complications along the way. But my story is written for me. That is now, from that point to your last breath, is time you never get back. I mean, all of our life is time you never get back, but we get second chances. We wake up the next day, we can go for this new job, we can try this new thing, we can sell this, we can buy this. But now sort of you know that your days are numbered and you don't get this time back with your family, with your loved ones. Make it count. Make memories and make it count for your heavenly life. If you're a Catholic or a Christian, make it count for your heavenly life moving forward. And remember him. There's nothing that he's gone through that you're not going to go through. Physical pain, he did it. Loneliness, he did it. Abandonment, he did it. Being ridiculed, he did it. And he did it with grace, poise, dignity, and love. All right, that's my homily, Father.
A good one it is.
Beautiful.
And on that, let's end with prayer. In the name of the Father, and of the Son, and of the Holy Spirit.
Amen.
Amen. Heavenly Father, you are the source of all goodness. You are the author of life. And we thank you for the gift of our lives. We thank you for the gift of our families' lives. Help us and strengthen us in this time to recognize the dignity of human life from conception to natural death. Remind us that there is always someone out there that loves and cares for us. We thank you for the great gift of palliative care, for the gift of this procession, for the gift of our doctors and nurses who take a personal interest in the life of those who are sick. We ask that you continue to strengthen them in their professions. And we pray that our government leaders and those in charge of legislations will come to see the beauty of palliative care and its intrinsic value to us as human beings. And we ask all these prayers through Christ our Lord.
Amen.
Amen. The Lord be with you.
And with your spirit.
And may Almighty God bless you, the Father, the Son, and the Holy Spirit.
Amen.
Amen.
Amen. God bless you, everyone. See you next time.
God bless.
Thank you.